Hello, everyone. I'm Stacia DeMarco, Content Editor of Occupational Health and Safety Magazine. Welcome to today's webinar, AI in Occupational Health, Reducing Administrative Burden While Preserving Clinical Judgment. Cority sponsors today's webinar. Many thanks to them. And fortunately, we have two experts with us today to discuss that topic. I'm talking about Julianna Gemme and Frances Andreacchi. Julianna is a product marketing manager supporting Cority's health solutions. Julianna has focused her career on the healthcare industry. She has experience working with innovative health tech software to improve the health and safety of both healthcare providers and patients. Julianna is passionate about advancing healthcare settings supported by innovative technology. Frances is a registered nurse and manager of solution engineering at Cority, supporting the delivery of employee health solutions globally. Frances has built her career across both clinical and technology settings. She brings experience working with health tech software to improve how organizations manage workforce health and safety. Frances is passionate about helping modernize health programs through practical, user-centered technology. Before we get started, a couple of housekeeping items. At the end of the presentation, there will be a Q&A session where Julianna and Frances will answer your questions. And you can submit a question at any point during the webinar. If you'd like to submit a question, you're more than welcome to use the Ask a Question console on your screen. And again, you can do that at any point during the webinar. If you have any technical difficulties during the presentation, click on the Help button that's located below the slide window, and you will receive technical assistance. And today's presentation is quite detailed, and I encourage you to keep it. You can find a copy of the slides under the Blue Resources tab. And after today's event, you'll receive an email containing a link to an archive of today's presentation so that you can go back and review it or share it with a colleague who might have missed it. All right, it looks like we're ready to kick off today's presentation, so I'll hand things over to Julianna and Frances.
Thanks so much, Stacia. Good morning, good afternoon, everyone. Thanks for being here and joining our webinar on AI and occupational health. I'm Julianna, Product Marketing Manager here at Cority, and my job is essentially to sit at the intersection of what our customers are dealing with and what our technology can do about it. And I'll be honest, the topic we're covering today is one I've been wanting to dig into for a while because there's so much noise out there about AI right now. And I think occupational health deserves a clearer, grounded conversation about it. I'm joined by my colleague, Frances, who is our Manager of Solutions Engineering. Frances, did you want to say a quick hello?
Hi, everybody. Frances here. I'm really excited to talk to you about AI today, and we can learn lots together. Thank you.
Awesome, thanks. So together, we're going to spend the next 45-ish minutes talking about AI and occupational health, what it actually is, what it can realistically do for your teams, and how to think about it in a way that's practical rather than theoretical. I want to set one expectation up front. We're not here to tell you AI is going to solve everything. We're here to have an honest conversation about where it helps, where the risks are, and what good looks like. Here's what we're going to cover today. We'll start with why AI is entering occupational health right now, because the timing isn't accidental and understanding the pressure behind it matters. Then we'll get into what AI actually is in this context, because I think a lot of the anxiety and a lot of the hype comes from people talking about very different things using the same words. We'll talk about what responsible AI looks like and give you a real checklist you can use, not just reassuring language. Then Frances is going to take you into our approach at Cority and walk you through some real workflow examples, actual use cases, running in real occupational health environments. We'll close with a framework for evaluating any AI tool you come across, and then we'll get into your questions. So please do send them through the chat as we go. We won't be able to respond in the moment, but we're collecting them and we're going to address as many as we can at the end. All right, let's get into it. So let's start with the why, because AI doesn't just appear in any industry, something drives it in. And in occupational health, what's driving it isn't excitement, it's pressure. I want to pose a question. You don't need to answer it, just sit with it for a moment. In the last week, how much of your time on your team's time went towards work that required your expertise? And then how much went towards documentation or data entry, chasing records, or completing forms? For most OH teams, that ratio is not what anyone would choose if they had a say in it. And the data does back it up. A recent Harris poll found that clinicians are spending nearly 28 hours a week on admin tasks. That's more than half of a working week, not on patients, not on clinical decisions, really on administration. Now, layer on top of that the compliance picture. Record keeping requirements are growing, regulatory complexity is increasing, and the workforce to handle all of it isn't keeping pace. OH teams are already stretched, and the pipeline of new clinicians coming into this field isn't closing that gap very quickly. For those of you who manage programs or teams rather than seeing patients directly, you're feeling this too, just from a different angle. It shows up in backlogs, in staff who are stretched thin, in the sense that your team is always catching up and never quite getting ahead. So AI isn't entering occupational health because it's trendy. It's entering it because the status quo has real costs for clinicians, for programs, and ultimately for the employees those programs exist to support. Before we go any further, I want to just slow down and talk about some definitions. When people say AI, they can mean anything from a basic autocomplete to a fully autonomous system making decisions without human input. That range is enormous, and the anxiety or excitement people feel about AI often depends entirely on which end of that spectrum they're picturing. So let's be specific about what AI means in occupational health today. At its core, it's about three things. The first being pattern recognition, which is the ability to read and sort information. When we say scanning, we mean the AI can read a document, paper form, a scanned PDF, a photo of a record, so that a person doesn't have to manually type everything in. When we say classification, we mean it can put that information into the right place. This isn't interpretation, it isn't clinical reasoning, it's just reading and sorting, just done faster and more consistently than manual entry. The second is natural language processing, so working with text. This is what allows AI to summarize a set of notes, extract relevant information from a longer document, or help turn a conversation into a structured record. The clinician always reviews and confirms the output. The AI drafts it, the human decides. And third, a decision support, which is where I want to spend an extra moment because that word decision in there can make people nervous. Decision support does not mean that the AI makes decisions. It means the AI surfaces relevant information so that a qualified person can make a better informed decision, and the accountability always stays with the human. And then there's the term AI agent, which you're going to hear more and more of. An AI agent is simply a tool that can carry out a defined task on your behalf autonomously, but with a very specific narrow scope and always with human review. And the reason occupational health is actually well suited for AI is that the workflows are structured and repeatable. So vaccination records, inspection forms, consent documents, these are not ambiguous, open-ended tasks. They're exactly the kind of work that narrow, task-specific AI can handle reliably, freeing up a team from work that needs a trained professional. So if AI is handling the reading, the sorting, the summarizing, what does that actually give back to your team? I want you to think about these four outcomes, not as product features, but as things that have probably come up in conversation with your colleagues, things people have complained about or wished were different. The first being returning time to clinical care. If documentation is taking up a significant portion of a clinician's day and AI can reduce that, the time doesn't disappear, it goes somewhere better back to the patient, back to the employee sitting across the desk. For clinicians, that's why a lot of them got into this field. And for program managers, that's where the team's actual value lives. The second is reducing variation in routine admin work. So when documentation is done manually by different people at different times, there can be some inconsistency. Notes structured differently, data captured in different ways. That variation creates problems downstream in reporting, in compliance, in continuity of care. And AI that handles routine documentation consistently removes a lot of that. The third being lowering cognitive load. So think about your team actually experiences across a full day, rereading the same record because the information they need isn't where they expected it, retyping data that already exists somewhere in the system, searching for something they know is there but can't locate quickly. That kind of friction is draining in a way that's easy to underestimate until it's gone. And then the right data at the right time. So not 3 screens deep, not after the appointment's over, just right there in the moment when a decision's being made. When these 4 things are working together, the job looks different. Not easier necessarily, but better. More of the work that drew people into occupational health in the first place, and less of that work that makes people burn out. So just want to pause here before we move into the risk conversation because this quote frames the whole vision. The best AI in occupational health operates quietly in the background, taking work off your plate without changing how you practice. So quietly in the background, not disturbing your workflow, not requiring you to learn a new way of working, just handling the burden so you can stay focused on what actually needs you. That's the standard we encourage everyone to hold in this AI space. If a tool is creating new work, new steps, new things to manage, it's just not doing its job. The goal is subtraction, not addition. So before we talk about what AI can do for you, we want to talk about what can go wrong. Because if we skip this part, we're not being honest with you or ourselves for that matter of fact. So there are risks that apply to AI across any healthcare setting. If the data going in is poor quality, the output is going to reflect that. There's a danger of teams becoming over-reliant on automation, where the habit of checking, questioning, and thinking critically starts to erode because the system usually gets it right. Bias can be embedded in training data in ways that aren't obvious until they cause a problem. And in any environment, handling sensitive health information, privacy, and security are non-negotiable. But occupational health has its own layer of risk on top of that, and it's worth understanding why. In most healthcare settings, the relationship is between a patient and a caregiver. In occupational health, there's a third party in the room, which is the employer, and that changes the dynamic considerably. You're often navigating the tension between what's best for the employee's health and what the employer needs to know or act on. That tension requires professional judgment and human nuance. It's not a tension that an AI system can resolve. A misread fitness for work assessment, a documentation error that doesn't get caught before a decision is made. These aren't just administrative problems. They can affect whether someone returns to work too early, whether they get the accommodation they need, or whether their employment situation changes because of something recorded incorrectly. That's where responsible AI in occupational health isn't just a nice phrase, it's a design requirement. And AI should be there to support the judgment of the professionals in this room, not replace it. So given everything I just described, the risks, the complexity of this environment, what does good actually look like? Because responsible AI can start to sound like some marketing language if it isn't backed up with specifics. So here are 6 things to look for, and I'd encourage you to use these as a checklist when evaluating any tool. The first being clinician in the loop. The technology should not move forward on a decision without a human actively in the chain, not as a formality, but as a real check with real authority to override. The second is medical grade language learning models. So a language model trained on general generic terms is fundamentally different than one trained and validated on clinical data. So in occupational health, that difference matters enormously. It's important to ask, what data was this model trained on and how is it validated for clinical use? The third being auditable data trails. So you should be able to see what the AI did and why. If something goes wrong, you need to be able to trace it in a regulated environment. That's not optional. The fourth being narrow task-specific use. So AI that tries to do everything tends to do nothing particularly well. So good AI has a defined job, does it well, and doesn't try to operate outside of it. Fifth, clear accountability. There should be no ambiguity about who owns the output. The answer should always be a person, not the system. And six, transparent outputs. So you should never be in a position where the AI gives you a result and you have no idea where or how it got there. If you can't interrogate it, you can't trust it, and in occupational health, trust is not optional. So I have a chart up on the screen. Take a moment to take a look at it. I think it reframes how most people instinctively think about AI risk. The natural instinct is to ask, is AI risky? But that might not be the right question. The better question could be, is this the right AI for this specific job? So if you look at the risk column, all three tools shown here, the medical scribe agent, the OCR scanning agent, and the chatbot, are rated high risk if they go wrong. That might surprise people, particularly with that chatbot, right? We tend to think of a chatbot as relatively low stakes, but in occupational health, incorrect guidance from a chatbot could lead to someone taking a wrong action on compliance or work access decisions. So what separates a good implementation from a bad one isn't the category of tool, it's what's underneath it. So let's say like the healthcare trained model that understands clinical context, or OCR that has logic checks and human review built in, a chatbot that knows its limits and escalates to a human when it reaches them. That bottom row, so what matters most, is really the set of questions we encourage people to ask when sourcing AI. Not just what does your AI do, but what happens when it's wrong and how did you design for that? So that's the landscape, why AI is here, what it is, what the risks are, and what responsible implementation looks like. Now the natural question is, what does this actually look like in practice inside a real system, in real workflows on a real day for an occupational health team? So that's exactly what Frances is going to walk you through now. So Frances, over to you.
All right, thank you, Juliana. I want to build on what she just walked through, because this slide is really where the philosophy behind our approach connects to the product itself. So we built our AI from the ground up. So at a foundational level, clinical judgment leads, accountability stays human, and trust is not negotiable. Those aren't just nice words on a slide. They were the guardrails for everything we built. And if something didn't support these principles, it just simply didn't move forward. Now, the second layer is design. So how AI actually gets embedded into the product experience. It builds directly into the workflows occupational health teams are already using every day. It's not another standalone tool or a separate screen people have to remember to open. It works within their existing processes and quietly supports the work happening in the background. So teams don't have to completely change how they operate just to get value from AI. The third layer is execution. So how intelligence actually shows up in the day-to-day workflow. So reducing manual work, helping surface useful insights from data already in the system, and supporting clinical and operational decision-making rather than trying to replace it. And then the final layer is outcomes. So giving teams more time to focus on the clinical work, identifying concerns earlier, creating clearer visibility into risk trends, and ultimately supporting better informed decisions. That's really the goal behind all of this. And we approach this from the foundation up because, especially in occupational health, we believe that's the only responsible way to build AI into these environments. So Let me show you what this actually looks like in practice. This is Cortex AI, Cority's embedded intelligence layer built directly into the Cority One platform. And I really want to emphasize that word embedded. This isn't a separate AI application that your team has to log into or another disconnected tool sitting beside the system already in use. You're not copying and pasting. It's built directly into the workflows, the data and the day-to-day routines teams are already working in. And I think that distinction matters more than most people realize. So in my experience working with occupational health teams, the biggest challenge with new technology usually isn't the technology itself, it's adoption. So if people have to completely change how they work, remember another login, or open a separate application every time, they won't use AI capabilities. Not everyone. Most teams just won't consistently use it. So not only because they don't see the value, but because they're busy, they're moving quickly, and existing workflows become second nature. Cortex AI was designed specifically to remove this friction. So the intelligence is simply there within the workflow at the point where it's actually needed. Your team doesn't have to stop what they're doing and go looking for it. So from a functionality perspective, it helps take the information that currently exists in physical or unstructured formats, paper documents, scanned records, handwritten notes, and turns that into usable digital data. It removes manual steps from the processes that today still require a lot of administrative handling, and it helps surface insights from your own data to support better operational and clinical decisions. Now, on the right side of the slide, you can see some of the specific capabilities. So this is document analysis, medical scribe, scan to form, voice to form, invoice scanning, and others. So we're going to go a bit deeper on a few of those in a moment, but what I really want you to notice here is the breadth. This isn't one isolated AI feature. It's an intelligence layer that touches multiple parts of the platform and multiple workflows across the organization. Okay, so this next slide gets into how Cortex AI was designed. So I think these three principles are important to spend a minute on because they directly address a lot of the concerns that Julianna had mentioned earlier around risk, trust, and governance. So the first is secure by design. So in occupational health, we're dealing with some of the most sensitive data. We have health information tied to employment, fitness to work, exposure history, case management, and regulatory documentation. Security and privacy can't be something layered on afterwards. The architecture has to be built around protecting that information from the start. The second is it's built to last. So honestly, this one matters more than it might initially sound. There are a lot of AI tools right now that look impressive in a demo environment, but become difficult to operationalize or scale in the real world. What organizations actually need is something that performs consistently over time, adapts as workflows evolve, and can grow with the organization. So not something that feels obsolete or disconnected a few years from now where you just abandon that entirely. And the third principle, governed by you, is probably the one I'd ask you to remember the most. So every AI-driven action or output within Cortex AI is observable, auditable, and ultimately controlled by the organization. You can see what the AI did, understand why it did it, and question the output and override it if you need to. So that's not a limitation of the platform, that's intentionally and how it was designed. And if you think back to the framework Julianna worked through earlier, that is really what concepts like clinician in the loop and transparent outputs look like in practice. The AI supports the decision making, but accountability and control always remain with the organization and the clinical professions using it. So now I'm going to dive in a little bit deeper and look at some real examples and what it looks like inside occupational health workflows today. And I want to walk through these three use cases that are already being applied in practice. So the first is the medical scribe agent. So this is built on a medical grade language model, which is important because it's specifically trained to understand clinical terminology, context, and the nuance that exists within patient interactions and medical documentation, not just a general language conversation. The distinction matters more than most people realize because generic AI models can misunderstand clinical terminology or misinterpret context in ways that may seem subtle, but can have real downstream consequences in documentation and decision-making. can be really inconsistent. If you think about a typical occupational health encounter today, the clinician is simultaneously trying to engage with the employee, gather information, gather health history, assess symptoms, make observations, and kind of mentally organize all of those documentation requirements in their head in real time. And all that information needs to end up in structured, defensible record after. So for most organizations today, that means one of two things happens. Either the clinician is documenting during the interaction, which leaves them not exactly very present with their employee, which can totally impact the quality and the flow of the conversation, or they're spending time after the encounter trying to reconstruct everything from memory. Rough notes, fragmented documentation. I know I used to set 2 hours at the end of every day just to complete my documentation. What the medical scribe agent changes is not the encounter itself, it changes the documentation burden that comes after it. So when activated, the AI can listen to the conversation between the employee and the occupational health professional, draft the documentation based on that interaction, and then present it back for clinician to review and approve. The clinician still validates the information, confirms accuracy, and maintains control over the final record. The outcomes organizations are seeing are more consistent documentation, reduced variation between providers, less administrative burden, and meaningful reductions in the cognitive fatigue that builds up over a full day of back-to-back appointments. I think that's really important. There's an actual published research beginning to support this as well. So one study found that just after 30 days, that's not a long time, 30 days of AI scribe use, clinicians reported a 13% reduction of burnout, which is actually pretty significant over a relatively short time. Okay, so the second use case is the vaccination scanning agent. And this is a really good example of a workflow that sounds straightforward on the surface, but becomes incredibly time-consuming and operationally heavy at scale. So think about how vaccinations actually enter occupational health today. They come from onboarding packages, external pharmacies and clinics, employee submitted documentation, scanned PDFs, handwritten immunization cards. Sometimes someone gets vaccinated over the weekend, walks into the clinic Monday, with a little piece of paper in their hand, and every single one of those little pieces of paper need to be reviewed, interpreted, manually entered into the system by someone. Someone has to actively do all of that, and sometimes we're dealing with tens of thousands of records. So when you're managing that process across a large workforce, it becomes a massively administrative burden. And the reality is, anytime humans are manually transferring data from one place to another at a high volume, inconsistencies and errors start to happen. That's unavoidable. I think it's important to visualize what this actually looks like operationally inside a busy clinic. So you've got stacks of paper records sitting at a desk. Someone is entering the information field by field and trying to work quickly, but carefully. They're doing their best, but they're also human. A name gets transposed, a vaccine manufacturer gets selected incorrectly, a date gets entered wrong, a dose gets missed. None of those mistakes are intentional, but every one of them has downstream implications for reporting accuracy, compliance tracking, and ultimately confidence in the data itself. What the vaccine scanning agency actually does is that it reads the vaccination record. It identifies relevant information like the vaccine type, the dose, manufacturer, and dates, and automatically populates that information to the employee's immunization record. So the outcomes are faster processing times, less administrative burden on clinical staff, fewer manual entry errors, and better overall data quality. From an organizational perspective, this translates into more reliable visibility into the workforce vaccination status, which matters not only from a compliance standpoint, but also from a workforce health and protection perspective. And there's research supporting this direction as well. So studies looking at OCR-based clinical data processing found lower documentation error rates compared to fully manual entry workflows, particularly around areas like prescription and vital signs, which you realize is different, but that aligns pretty closely with what we're seeing operationally. And fewer times humans have to manually enter data, the fewer opportunities there are for errors to occur. Okay, and last, so for the third use case, questionnaire scanning agent. So honestly, this one tends to resonate with almost anyone who has ever dealt with paper-based forms at scale. So whether it's inspections, health questionnaires, consent forms, surveillance documentation, employee surveys, anything. The issue with paper isn't that it's slower, it's that the real issue is that everything still has to happen after the paper arrives. So someone still has to sit there, they have to read the handwriting, they have to interpret the responses, manually enter all of that information into the system, field by field, before the workflow can move forward. And when you think about how much of occupational health still depends on forms and documentation, that administrative work adds up incredibly quick. It becomes a huge amount of repetitive manual effort that pulls skilled people away from higher value work that they should be doing instead of focusing on instead. So operationally, this process is also just as efficient. For instance, health questionnaire identifies a concern, but it's still waiting for manual data entry before the next step can happen. There's a lag between collecting that information and being able to operationalize it. So what the questionnaire scanning agent does is it removes that gap entirely. This document gets scanned, the AI extracts the structure of information automatically, and the digital record is created within the workflow, ready for review and action. So instead of spending time redocumenting what was already captured on paper, teams can move forward directly into addressing that issue itself. The outcomes are pretty straightforward. So we're reducing administrative workload, faster workflow progression, improved turnaround times, and better overall efficiency for teams processing high volumes of forms on a regular basis. So even just think of consent forms. If you're not doing your consent forms or flu clinic electronically and you are able to just scan them and have them completely uploaded in a format that is kind of deconstructed so that you have that there, you have it electronically. So there's emerging research supporting this approach. A 2025 multi-center healthcare found that OCR-based form scanning reduced documentation time by roughly 44%, while still maintaining high levels of data accuracy compared to manual entry workflows. And for organizations processing large volumes of inspections, surveys, or clinical forms, that became a very meaningful operational time savings. Okay, so I really like this slide because I think it captures in a very practical way what working with AI in occupational health is actually supposed to look like on a day-to-day. So if you look at the left, it's things like manual data processing, repetitive administrative work, searching for documentation, documentation handling, all of the operational tasks that consume a huge amount of time, but don't necessarily add clinical value. And honestly, if we're being realistic, those are not things most people went into occupational health to spend their day doing. So then you look at the right side, clinical judgment, decision-making, employee interaction, professional accountability. These are the parts of the job that actually require human expertise, training, and experience. And most importantly, context. These are the areas where people really matter the most. So what we're talking about here is not replacing occupational health professionals. It's creating a better division of labor between the people and the technology. So the repetitive administrative workload gets reduced or automated. Yay. And your team's time and energy can shift back toward what genuinely benefits from human involvement. So because at the end of the day, the goal isn't to remove people from the process, it's to remove friction from the process. So your clinicians and occupational health teams can spend more time focused on the parts of the work that actually need them. And that's really what this is designed to do. Okay, so we're getting close to the end, and I want to leave you with something practical and useful, regardless of whether you're a clinician, an operational leader, or someone responsible for evaluating technology decisions for your organization. If you're assessing AI tools for occupational health, I really think you need to look at these 7 questions. I think they're really worth asking. So, does it keep me in the loop? Can I override or correct it easily? Is the output explainable and auditable? Does it fit naturally into my existing workflow? Does it support my clinical judgment, not replace it? And is it scalable as my business grows? And finally, is it trained on healthcare and OH relevant data, not just a generic AI? All of these questions matter, but honestly, the last one is probably the one I push the hardest on. So was the AI designed with healthcare and occupational health workflows in mind from the beginning? Because that context matters. Occupational health has unique workflows, terminology, regulatory considerations, and documentation requirements that are very different from many other environments. And when you're talking about employee health information, clinical decision support, compliance and workforce risk, accuracy, reliability, and transparency become incredibly important. So I do think it's worth asking those questions directly when evaluating AI solutions in this space. Okay, so where is this all heading? I want to give you an honest picture of what the next 1 to 3 years look like in occupational health from an AI perspective. And it's not a hype vision, but what we think is a realistic in the nearer term. So on the left, we have things we expect to see more of. So smarter document intake and data extraction, less friction from getting information into the system in usable form, more effective triage and case prioritization. So helping teams focus on what needs attention first. Workflow automation that reduces administrative burden, decision support that surfaces the right information at the right time while keeping clinicians in the lead, and automated chart analysis and case categorization, the kind of background work that currently takes a lot of manual effort and mental load. And now on the right column, and I actually think this is the more important one to read carefully, is what AI will not do in occupational health, at least in any responsible implementation. So it is not going to replace clinical judgment or decision making. It will not deliver fully autonomous clinical care. It will not eliminate the need for human oversight, and it will not work reliably if it's built on a generic AI without clinical context. There's a lot of noise in the market right now of what AI can do, and some of it is overstated. All right, so key takeaways. We've covered a lot of ground today, and I want to bring it back to the 4 points that I think matters most. So first, AI is already here in occupational health. The question is, at this point, really wasn't whether organizations are going to encounter AI, it's whether they're going to encounter it in a form that is actually designed responsibly for healthcare and occupational health environments. Second, narrow and task-specific AI tends to deliver the most value with the least amount of risk. So in my opinion, the tools that try to do everything are usually the ones that create the most problems. So the tools that are designed with clear boundaries, focused workflows, and specific operational objectives are the ones that organizations can actually trust and operationalize successfully. And third, clinician oversight remains absolutely non-negotiable. Non-negotiable. Everything we've shown today is designed to work around that specific principle. So the human remains in the loop, accountable for the outcome, and ultimately in control of the decision-making process. The AI supports the work, doesn't replace professional judgment. And fourth, and honestly, probably the simplest way to summarize this entire conversation, the goal is to spend more time on clinical thinking and less time spent on moving data around. So that's really what all this comes down to. And I had actually encourage you to hold on to that statement on the right side of the slide as a filter for evaluating anything in this space. AI should make occupational health more human, not less. Because if technology isn't going to improve the human side of the work, the clinician experience, employee interaction, the quality of decision-making, the ability to focus on meaningful care and operational support, then it's probably not solving the right problem in the first place. Okay. So thank you for all being here today. We really appreciate you giving your time. We hope you're leaving with a clearer picture of AI and what it actually looks like, and what it's done thoughtfully and what it should actually do, and what questions to ask when you're evaluating it. And with that, let's open it up. If you have any questions, we're happy to dig in. You can please type in the chat function.
Yeah, and as we're moving into those questions, you'll see a poll on the screen, so feel free to answer to whichever applies to you if you would like to connect with a Cority expert to discuss this topic in more detail as well.
All right, that was a great presentation, and not surprisingly, we have some great questions. So let's dive on in and answer some of them. First question, will the medical scribe record phone calls?
Yes, so you can just put your phone on speaker. So we've definitely seen a lot of people use it this way. So there might be a return to work phone call or something like that. Yes, you can absolutely put your phone on speaker. It also connects to Teams and your audio on your computer, and it will capture that dialogue and that conversation with the ambient listening and record it accordingly. So absolutely, yes.
How does questionnaire creation handle skipped mandatory questions?
Good question. So you can't actually submit the question with a questionnaire without completing those mandatory questions. So if it didn't pick it up, or if it wasn't part of the questionnaire that was actually manually completed when it was scanned, then you can still actually go in, complete that question manually before you submit. So you're still going to get those mandatory questions.
What is the expected timeline for rolling out Cortex AI?
I can take this one. So great question. The rollout for Cortex AI, it's designed to be fast and straightforward. Typically, we see it's about a 4-week time frame from start to finish, and also with that will come like some training and resources to make the adoption smooth across the teams.
All right. How is Cortex AI secured, and what measures are in place to protect data?
Yeah, so I know we mentioned it a few times in the presentation, but Cortex AI does use a secure domain-specific data set, and it ensures the sensitive data is never compromised. So we've said it a few times, all the outputs are fully observable, auditable, traceable, really making sure that the human is in control at every single stage.
Now, when it comes to translation, can AI translate between a clinician and a patient who speaks a foreign language, such as Arabic or Kurdish?
Frances, do you want me to take this one?
Sure.
Yeah, so I think this one, like, certainly reach out to us directly, because I think there's going to be more along with this conversation. We do have other languages available, though, with the medical scribe. Feel free, Frances, if you have more info on that to say it. But
yeah, I've actually seen one of our AI agents work in a completely different language. My manager basically said an entire description of an incident in Arabic, and it actually translated it into English.
All right. Well, it looks like we're getting ready to wrap up our Q&A. I want to thank everybody so much for being so generous in helping the audience. Remember, everybody, in the next day or two, we will email you a link to the archived version of this webinar so you can view it again or share it with someone. Also, if you want a copy of the slide deck, you can get it under the Resources tab. And before we sign off, 3 notes of thanks. First, I want to take a moment to thank our experts, Julianna, Gemme, and Frances Andreacchi. Also, I want to thank today's sponsor, Cority. Many thanks to them for making today's program possible. And also, I want to give a special thank you to those who participated with us today. You're the reason we do this, so thanks very much for your interest and involvement. And with that, I hope everybody has a great rest of the week. But for now, goodbye until the next Occupational Health and Safety webinar.